afternoon, and I hope everybody had a nice lunch. Final request to those of you at the back, can I please request that you occupy the seats as we start session 3. So the next session that we have is called Tuberculosis, Challenges, Milestones in Looking to the Future. I want to introduce the chair for this session, which is Petrus. Many of you know Petrus, who spent about 6 years in India as research coordinator with MSF OCB in Mumbai, and he now works with the South African Medical Unit as a operations research advisor. So Petrus, welcome, and we move into the next session.
Well, you will not see my name in the leaflets because actually I'm sitting on behalf of Dr. Rohit Sarin, who unfortunately, he didn't manage to make it today to chair this session. So I will do my best to do this role of Dr. Sarin. So I think we have a very interesting lineup of presentations. Actually, we have 2 very interesting presentations on TB and one a really fascinating speech of one TB advocate that I'm sure that you will really not just enjoy, but you will reflect and you will realize that this kind of voices are not really heard so often. So before, I would like to introduce first the first speaker of the first session, Hemant. So Hemant Shewade is a doctor in family medicine. And he's currently working with the union, the International Union for Tuberculosis and Lung Diseases. I know Hemant personally. We work together in different parts of South Asia in very exciting courses. He's facilitating courses, called sorted courses, Structure Operational Research Training Initiative. And we have been doing this work for quite some time now around Southeast Asia. So Hemant will present some very interesting data from a project that I guess some of you who are in the TB world have heard about, the project Axshya, which is actually a massive project in size and in importance. So I think Hemant will share with us just one small piece of this huge mine of information that the project Axshya has been collecting around India. So Hemant, please.
Thank you very much, Petros, for that lovely introduction. So what I'm going to speak for the next 10 minutes is on active versus passive case finding, patient characteristics, health seeking, and delays among new smear-positive pulmonary TB patients in India. So as some of you might be knowing, and many of you who are working in TB might be knowing, that the national TB program in India is based on the strategy of passive case finding, where the patient or the person who suspects that he has cough or he could have TB goes to a nearby laboratory, which is called as a designated microscopy center, gets him or herself tested, and if he or she has TB, they are put on treatment. So this is called as passive case finding. So what I'm going to present here is the findings of active case finding strategy that Project Axshya has been implementing throughout India. And in this presentation, I'll be focusing on the reduction in delays. There are other aspects as well, that is the effect of active case finding on reduction in catastrophic costs due to TB diagnosis, effect of active case finding in increased TB case notification, effect of active case finding on, say, improved TB treatment outcomes. They are separate research papers. I'll not be presenting them here. So let's begin. The study group is called as the Axshya Samvad Study Group. This study group includes co-investigators from the union, which is the primary recipient of Project Axshya, then the sub-recipients of Project Axshya, the implementing NGOs. Number 3 is the national and state level program managers of National TB program. And the third set of investigators are from national academic institutes from AIIMS and PGMR Chandigarh. So I'm representing this Axshya Samvad study group. Let's begin. Okay, let's give a background of Project Axshya. This project is being implemented by the Union Southeast Asia Office, which is based in New Delhi. The Union stands for International Union Against Tuberculosis and Lung Disease. Axshya in Sanskrit means Akshaya. Kshaya means TB, means without. So Project Axshya means we are aiming for a world without TB. This project is implemented in 285 districts out of roughly 660 districts of the country, and I'll be using the term Axshya district to denote these districts. Now the principle behind this Project Axshya is that it uses two strategies. One is ACSM, which is called as Advocacy, Communication and Social Mobilization. And the other component, the very important component, is active case finding, that is community-based active case finding. So what it aims to do by ACSM and ACF, that is community-based active case finding, is to enhance the reach and visibility of the National TB Program in marginalized and vulnerable communities. So as I told you in my introduction that the National TB Program has a passive case finding strategy, and its staff is up to the level of a designated microscopy center, which is at the level of a population for, say, a 1 lakh population. Well, 1 lakh would be 100,000. 100,000 population would have one designated microscopy center, and that is where they have a laboratory technician. Below that, there is no staff present. So, through ACSM and ACF, the project aims to enhance the reach and visibility of the National TB Program, hoping to eventually mitigate the impact of TB on the community. So the Project Axshya, it's been in various phases. The current phase that I had looked is 2016-17 phase. That depends on funding, basically. So all the phases are dependent on funding. So it begins with mapping of, the marginalized and vulnerable population. So there was a definition of marginalized and vulnerable populations, and the Project Axshya team at district level in these 285 Axshya districts, along with the district TB team, would first carry out a mapping exercise to identify which are the marginalized and vulnerable communities, and this is where a project is going to target its activities. Fine. Now, coming to Axshya Samvad. Axshya Samvad is the community-based active case finding strategy. We have given the term Axshya Samvad because Axshya, we know the meaning, without TB. Samvad in Hindi means conversation or having a dialogue. So therefore, it is Axshya Samvad, having a dialogue with the community. It is also called as sensitization and advocacy, and there's a bigger acronym. I won't get into it. So the strategy is called as Axshya Samvad, which is a community-based active case finding strategy. And in this, trained community volunteers go house to house, educate households in these marginalized and vulnerable communities about tuberculosis. And if they find a person with presumptive TB, the focus here is pulmonary TB. If they find a patient with presumptive pulmonary TB, they refer the patient with a referral slip to the nearby designated microscopy center. And if there is a failed referral, what I mean by failed referral is referral done, but the patient doesn't go. There were some processes within the project as to what is a failed referral. Then a sputum collection and transportation is done. The community volunteer himself or herself collects the sputum and transports it to the designated microscopy center. So this is, in short, the Axshya Samvad strategy. The background, if I look at any screening strategy for active TB, I've discussed in my initial slide that there are 4 things that you look for to see whether it's effective or not. Number 1, it should detect cases. If it doesn't detect cases, it's of no use. Number 2, it should detect cases earlier than passive case finding. If it is detecting cases at the same time point when compared to passive case finding, then there's no point, investing resources for active case finding. Number 3 is it should, reduce the costs for the patient. That is, the understanding is if it reduces diagnosis delay, the out-of-pocket expenditures and the catastrophic costs that the patient will incur will reduce. Another thing is you expect that these patients to have better treatment outcome when compared to patients detected through PCF. This is expectations, because these patients are detected early. And the final thing is you expect overall TB transmission to come down. That is the final goal of any screening strategy for tuberculosis, to reduce the TB transmission. Now, Kranzer et al. In his systematic review said that screening found cases earlier with less severe disease, yes. Then, but what was the shortcoming in those studies? The shortcoming was the reviewers suggested that this might be due to more sensitive tests, diagnostic methods that are used in studies when compared to routine program. So someone implements a active case finding strategy or a community-based strategy, but they use, say, expert or something else. You know, the diagnostic algorithm or the diagnostic techniques and tools were different. So they suggested that we don't have studies where you could, you know, you have the similar diagnostic algorithm and similar tools. The only difference was a patient being detected by ACF and other patient detected by PCF. So there is a lack of evidence in this regard. So therefore we conducted this study, the Axshya Samvad study. The objectives of this particular study that I'm going to present is, among new smear positive pulmonary TB patients belonging to marginalized and vulnerable populations and registered under the India's National TB Program between March 2016 to Feb 2017, to compare among those detected by active case finding and passive case finding, number one, patient characteristics, healthcare seeking, and various delays from eligibility for sputum examination to treatment initiation. I won't be covering other aspects of cost, treatment outcomes, and case notifications in this presentation. So the methods, it was an observational analytic design involving secondary data as well as primary data collection, and the study was approved by the Ethics Advisory Group, and administrative approvals were taken from the respective state TB program managers. Now, this map of India shows the study districts that we sampled. So out of the 285 Axshya districts, we randomly sampled, using simple random sampling, 18 Axshya districts to be included in this study. These 18 studies happen to belong to 7 states. Now you could see Bhatinda is, so it is spread uniformly across the country. Now methods, let's go to the study participants. As mentioned, the objectives, these were new sputum smear positive TB patients from marginalized and vulnerable populations. And these were registered, so we divided them into 2 groups. One is ACF, that is all newly registered patients that were detected through active case finding. So you have a TB register within the program, and then you identify which of these were detected through active case finding. Then an equal number of randomly selected newly registered patients that were detected through passive case finding. So you had 18 districts, so every month patient get registered. We see, okay, if 2 ACF patients were detected, say 2 patients were detected through ACF in a district in 1 month, among the other passive case patients detected through passive case finding, we would randomly select 2. So if you look at the end of 1 year, we selected all active patients detected through active case finding and a random sample of patients detected through passive case finding. What we did is we excluded a certain group of patients where we thought there could be a contamination of exposures. For example, patients detected through PCF from an area where ACF activity was done in last 6 months. So we were not sure whether it was the whole contribution was because of passive case finding or whether there was some contribution of active case finding as well. So these patients we excluded from our analysis. So this is a figure summarizing the delays that we're trying to measure. So there are these 4 dates here. One is eligibility for sputum examination, which is your 14th day of fever or 14th day of cough or the first day of hemoptysis, whichever is earlier. Then you have the first consultation with a healthcare provider, then the confirmation of diagnosis, and then start of treatment. So you have 3 time periods here. The first one would be called as a patient level delay. That is between eligibility for sputum examination to first consultation with a healthcare provider. HCP is a healthcare provider. Then from first consultation to date of diagnosis, this is health system level diagnosis delay. And then from confirmation of diagnosis to start of treatment, this is called as your treatment initiation delay. So just to clarify, the date of diagnosis and date of treatment initiation was through record review, routine data in the program, and eligibility for sputum examination, the date and date when first consulted and a healthcare provider was through patient interviews. Now we also got some baseline characteristics, which were some from record reviews, some from patient interviews, and we also calculated the number of healthcare providers visited in this process. Fine? Okay. Now let's go through the results. First, the patient characteristics. There were 465 patients during the study period, 234 ACF and 231 PCF. Now, first let me compare the patient characteristics relevant to the marginalized and vulnerable status of the population. So compared to PCF, ACF patients were more marginalized than vulnerable. So more ACF patients were old, More ACF patients did not have formal education. More ACF patients had lower monthly income per capita for their respective households. They were from rural areas when compared to PCF. And more patients from ACF lived farther away from the microscopy center when compared to PCF. This is a proxy indicator that the project was actually going to the marginalized and vulnerable, and within them, more marginalized and vulnerable. So remember, all these patients, ACF, were from the marginalized and vulnerable populations. Now going to patient characteristics, which is their clinical profile. Compared to PCF, ACF patients were less sick at diagnosis. So that's good. That means you're catching them early. Fewer patients had a history of significant weight loss, and fewer patients had a sputum grade of 3+ in ACF group. Now coming to health seeking, the second part of the objective after patient characteristics. Compared to PCF, ACF patients had significantly fewer HCP visits, basically half. So in PCF, the median number of healthcare provider visits from sputum eligibility to diagnosis was 1, and in PCF group it was 2. So there was reduction in the number of healthcare providers visited. The assumption is the case was picked up early and referred, or sputum was sent for diagnosis. Now the interesting part, which is delays. Compared to PCF, ACF patients had significantly lower health system level diagnostic delays. So it was 5 in ACF group and 19 days in PCF group. So a reduction of 14 days in the health system level diagnostic delay. That is from first healthcare provider visited to the date of diagnosis. Higher treatment initiation delay though. So the ACF patients had higher treatment initiation delay. So that was 4 in ACF group and 2 in PCF group. We'll discuss this later. Why? Now this was also confirmed through an adjusted analysis when we adjusted for all the variables that we collected. Remember, we did patient interviews, so we could collect an exhaustive list of variables that could also have an impact on the delays. Now to conclude, the Axshya Samvad linked the most impoverished communities to TB care and resulted in reduction of health system level diagnosis delay. Everyone would agree with that, between the first healthcare provider visited and diagnosis. But the project needs to take steps to ensure timely initiation of treatment. Let me explain this here. So this is to do with the honorarium that the community volunteer got. So the honorarium was for 2 things. That is number of household visited for the Samvad, or for the dialogue with the households. So if he visited 10 households, he would get 10 into 10, 100 rupees. If he or she visited 100, he or she would get 1,000, basically 10 rupees per household. Second honorarium or incentive was for every sputum collection and transport done. So if they did 100, they would get 50 rupees or 100 rupees per sputum collection and transport, subject to 7% of them are positive. So there was a quality control. But after diagnosis, there was no incentive provided to the community volunteer, whether the patient gets notified, whether the patient is initiated on treatment or not. So it all dependent on, and one more thing is, in ACF, patient is sitting at home, and you come and get the sputum and go get him or her diagnosed. And project data showed that 90% of the diagnosis was through sputum collection and transport. Only 10% was through referral. So in sputum collection and transport, the patient is sitting at home, the diagnosis happens at the lab, patient is less sick, less keen, you are the one who came and said that you have TB. So therefore, this explains the delay of 4 days in ACF group and 2 days in PCF group. This is our speculation. We have not confirmed it using qualitative interviews. So therefore, not based on these studies, but what I could tell is that our findings supports the Indian government's decision to scale up active case finding activity in all the districts as per the National Strategic Plan. Because the plan came before the results came in. So when we have shared these results, they're pretty happy with the results, saying that, okay, this supports our decision of scaling up ACF. Future research, we are going to, there is need to, we have done this with effect on catastrophic cause due to TB and also effect on TB treatment outcomes. Now the strengths, the biggest strength, I quoted Kranzer's systematic review of 2013 published in IJTLD. ACF and PCF patients were tested within the same microscopy center and underwent the similar diagnostic algorithm with the same diagnostic tools. That is sputum microscopy and X-ray. X-ray is not relevant here because there was new sputum positive pulmonary TB patients. There were some limitations as well. I would not say there were no limitations. This study was conducted in operational settings. It was not a funded study. You have 18 districts, 18 districts spread across the countries. That's why you see the authorship. There's so many people involved. You had to, train people who had to go to patients' residence to interview them. And many of these places are far, far away, say 60, 70 kilometers away from the nearest, urban area. So of the 573 that were sampled, only 465 were included in the study because we couldn't conduct interviews for 108 patients. That is 19%. And we have accepted this as a limitation. Distribution of two key variables, that is residence and sputum grade. We could get this information from record review, obviously not from patient interviews because we couldn't do them, was not similar in those interviewed and those not interviewed. So this is, you'll have to take these results with a pinch of salt. Diagnosed patients that underwent initial loss to follow-up are not included because we included registered patients, patients who are registered for treatment. So there could be many patients who were detected by the project, but they did not get initiated on treatment. So such patients were not included in the study. It's applicable both for the active case finding as well as passive case finding group. We only included new sputum smear positive pulmonary TB patients. We did not include previously treated. We did not include smear negative patients. There's a specific reason because number one, the project focused, the key outcome of the project was to detect new sputum smear positive pulmonary TB. And for smear negative pulmonary TB, it was a bit difficult to get history as to when is the actual onset of symptoms. And if someone has previous history of TB, it again becomes difficult, whether the cough or the onset of symptoms is a continuation of previous TB or is it related to the current episode of TB. Hence, we took a call for these two reasons to include only new smear positive pulmonary TB patients. Thank you very much.
Thanks, Hemant. This was very engaging. Can you hear me? This was very engaging. We needed after the lunch break and engaging. Just to know. Can you hear me now? Yeah. So I was saying that just to share a little bit during our work at the editorial committee for the scientific day, when we reviewed Hemant's and the union and his colleagues' abstracts, at least personally I can say when I read, I said, sputum smear microscopy, I said, what these guys are doing? I mean, I found like so outdated. But at the same time, when we looked later, we saw that actually this was a very important work because, as you said, it gave a unique opportunity to compare these two strategies, active versus passive, using the same diagnostic technique. So any difference could be attributed to the actual case-finding strategy rather than to the diagnostic test. But just from my side, as from the chair, I would like to say that actually one of the interesting things also of this study, before we take your questions, is that it generates more hypotheses and questions for the next studies. We're really interested to see about qualitative evidence from patients' perceptions, catastrophic out-of-pocket expenditure, and outcomes. Yeah. Actually, this is also something that all of us want to see. At the end of the day, it doesn't matter if you don't manage to get better outcomes from the patients, even if you treat them earlier. So let's take some questions. We want to take them at the end.